Hello everybody, I'm Stephen de Koning. I'm the chair of the European Teaching Group of Orthopedic Medicine. And through this film I would like to guide you a little bit more in your orthopedic medicine discovery process. Because most likely recently you visited our website and you completed the online clinical reasoning test. Well, I'm really very happy that already many people did this online test. But on the other hand, I'm also a little bit surprised. And probably you were also a little bit surprised when you got my email with the feedback on the clinical reasoning test, more specifically your score. And I can imagine that many people were at first a little bit disappointed with a rather low score on this test. But if you didn't do a training program yet in modern orthopedic medicine, then it is obvious that the score is rather low, because objective clinical reasoning is absolutely not easy. Well, through this film I would like to guide you a little bit more, and I suggest that we have a look at the 10 questions, and we're going to analyze each question separately and each answer, so that you have let's say a more clear view on objective clinical reasoning. So, ready for the challenge? Okay, here we go. Well, the first question: where can the pain be felt in case of a unilateral sacroiliac arthritis or a unilateral facet lesion? Well, there is one thing you have to keep in mind. There's a general rule in orthopedic medicine that says that a unilateral structure only causes unilateral pain. A unilateral structure only causes unilateral pain, so it cannot cause pain on the midline. The second rule: there are some rules of referred pain. Soft tissue lesions refer pain in a segmental way, so that means in a specific dermatome. There is an exception to that rule, the dura mater, but we talk about that later. So if you look at the answers, well, where can you feel pain in those cases? Unilateral segmental referred pain? Yes. Unilateral multisegmental pain, more than 3 dermatomes? No. For instance, sacroiliac lesion can refer pain mostly in maximum 2 dermatomes, S1, S2 dermatome, and a facet joint lesion is also going to be in 1 or maximum 2 dermatomes. Spinal pain on the midline? Of course not, because we talk about unilateral structures. They only cause unilateral pain. Can it cause local pain over the joint? Yes. Can it cause bilateral low lumbar pain? No. It's a unilateral structure, only causes unilateral pain. Okay? Question number 2. Clinical image in which passive movement in a joint is limited and painful in only one direction, and it is not limited but possibly painful in other directions. Well, that's typical for an internal derangement. An internal derangement, for instance, in the spine, an acute lumbago. The patient is blocked in flexion. He has a flexion deviation position. He cannot go to extension anymore. He can perform flexion, it's going to be painful, but extension is going to be completely impossible and blocked. Or internal derangement in the extremities, for instance, an acute meniscal lesion in the knee, where extension is also completely blocked. Flexion is painful, but still possible. Acute ligamentous lesion, here the answer is no. Acute tendinous lesion, no. By the way, an acute tendinous lesion is never going to cause limitation of passive movement. Acute arthritis, no. Acute muscle belly lesion, well, here the answer is yes. An example is, for instance, an acute muscle belly lesion gastrocnemius. muscular tear in the gastrocnemius, well, you may be sure that your passive dorsiflexion of the ankle is going to be quite painful and quite limited because of the muscle spasm around the lesion in the muscle belly lesion. So an acute muscle belly lesion very often gives limitation of passive movement in a certain direction because of the muscle spasm. Chronic muscle belly lesion, no. There is no limitation of movement. The movement, some certain passive movements could be painful, but there is no limitation of movement. The end feel on passive movement testing is hard in an acute stage of an arthritis? No, certainly not. In an acute stage of an arthritis, the end feel is going to be muscle spasm. Harder in case of an arthrosis? Yes. Muscle spasm in case of an acute bursitis? Yes. Springy block end feel in case of an acute meniscal problem? Yes. Harder in case of an elbow loose body? No. No, it's going to be softer. Your elbow extension, your passive elbow extension is going to be limited. Not that much, but the end feel, the normal end feel is hard, but if a loose body is interfering, the end feel could become more soft. Number 4 is a tricky question, and most of the people who fill in the test don't have a correct answer to that question, but I understand why. If a resisted test is painful and or weak, what could be the problem? Not an arthritis. In an arthritis, you have very clear positive passive test. But your resisted test, maximal isometrical contraction from a neutral position, they are negative. The passive tests are the main positive test. Mononeuritis. That's possible. For instance, a mononeuritis of the suprascapular nerve interfering with supraspinatus and infraspinatus could cause a weakness of resisted abduction, resisted lateral rotation in the shoulder. That's possible. Acute tendinitis? Yes, that's possible. An arthritis stage 1? Of course, there won't be any positive resisted tests. They're just positive passive tests. Acute internal derangement? No, passive tests are positive. Complete tendinous rupture? Yeah, your resisted test is not going to be painful, but it's going to be clearly weak. Fracture? Oh yes. For instance, olecranon fracture in the elbow. Your resisted extension in the elbow is going to be painful and weak at the same time. Partial tendinous rupture? Well, of course, your resisted test is also going to be painful and a little bit of weakness. Let's go to the shoulder. Shoulder weakness on resisted lateral rotation can be caused by an infraspinatus tendinous rupture? Yes. Long thoracic? No. Bursitis? Certainly not. Severe C6 nerve root compression? No. Resisted lateral rotation is a C5 action. Suprascapular nerve neuritis? Well, I just mentioned it before in the previous question. Of course, yes, that's possible. Axillary nerve palsy? No, that's more abduction and not lateral rotation. Severe C5 nerve root compression by hypothetically a disc, more likely an osteophyte for instance, then this is possible. Resisted hip flexion is painful. What could be the cause? An L2 nerve root compression? No. It could be weak, but the resisted hip flexion itself is not painful. The patient can have pain, but the test is not painful. You see, in clinical reasoning, objective clinical reasoning and a good functional examination, we really have to pay attention to the details. Neuritis? No. L3 nerve root compression? No. Yeah, they all have pain, but the test is not painful. Subacute arthritis? No. Psoas muscle lesion? Yes. Acute psoas bursitis? Yes, the resisted test could be painful due to compression of a very highly inflamed inert structure. And the rectus femoris lesion? The answer here is also yes. Of course, palpation is also going to play an important role over there. Cervical spine. Which combination of signs could suggest the presence of cervical neurofibromas? In other words, which are some red flags? Well, option A, unilateral root pain becoming bilateral, that's not favorable, so yes. Root pain disappearing after 6 months? No, that's good. So here, no. Biradicular neurological deficit? That's not good. So, yes. Arm pain on coughing? Also, yes. It still could be a lateral disc protrusion with pressure against the nerve root, but we have to be on the safe side. We have to rule out other problems. And then finally, root pain in a patient younger than 25 years old. This is also a red flag. Yeah, you don't expect lateral disc protrusions with pressure against the nerve root in patients below the age of 30-35. That's an empirical element, but nevertheless an important element. And then lumbar spine. Backache and or sciatica which appears on standing and walking, which is relieved within a few minutes on sitting and lying. Is that related to a neuroma? No. Is that related to a posterocentral internal derangement? Is that typical? No. Mushroom phenomenon? Oh yes. That's the story of a mushroom phenomenon. But you don't see that very often. You only see that with quite elderly people. Self-reducing nuclear protrusion? No. Spinal canal or lateral recessive stenosis? Yes, that could be possible. They have pain on walking and standing, which disappears on sitting and lying. And exactly the same for a spondylolisthesis. Yes. So let's imagine you find a spondylolisthesis on palpation, or you see a spondylolisthesis on medical imaging, and the patient has certain symptoms. Then 1 + 1 is 2. No, 1 + 1 is 3. Always listen to the story. If you see spondylolisthesis, but you don't hear this story, pain on walking and standing, which disappears on sitting and lying, then the spondylolisthesis is completely asymptomatic. Then the reason for his pain is something else. That's something that is really important to keep in mind. Okay? All the puzzle pieces have to fit. This is one of the key elements in orthopedic medicine. You're looking for puzzle pieces in the story, the inspection, the functional examination. And that's of course what you learn during our courses. Details are important. By the way, most of the spondylolistheses are asymptomatic. A lumbar patient has a lateral deviation to the left or to the right. What could that be? A symptomatic L4 disc protrusion internal derangement? Yeah, that's possible. A symptomatic L3 yes, that's possible. A symptomatic acute sacroiliac arthritis? Yes, that's also possible, but very, very uncommon. Sacralization? No. Lateral recessive stenosis? No. Facets joint dysfunction? Certainly not. That never gives a deviation. So, moral of the story, a lateral deviation. A lateral deviation without rotational component. In the absolute majority of the cases, this is related with a symptomatic internal derangement. And it also tells me that the internal derangement is larger. It's a bigger internal derangement. You will need more time to reduce that. And then the final question. A moderate partial articular pattern in the lumbar spine in combination with a painful arc on flexion or straight leg raise is typical for what? Well, perhaps first I have to explain what is a partial articular pattern. Well, a partial articular pattern is every pattern which does not correspond with what we call the full articular pattern. And what is the full articular pattern? Well, look at the patient's movements. What are you going to see? Extension in standing. Side flexions or side bending in standing are equally limited. And flexion is the best movement. This pattern we call the full articular pattern, which is typical for an arthrotic patient. So everything which does not correspond with that pattern, so any other combination, is automatically a partial articular pattern. So a partial articular pattern with a painful arc on flexion or straight leg raise, well, this is typical for an internal derangement, and it is typical for an easily reducible internal derangement. It's a small problem. You're going to be very fast successful with certain treatment strategies. It's not typical for a self-reducing one, certainly not for a bigger one. Yeah. Deviation, a lateral deviation or a flexion deviation is more typical for a bigger one. The problem certainly has no psychogenic nature. Indeed, this is correct. Psychogenic patients never show a painful arc. But to discover a painful arc, you have to perform your clinical examination in a correct way, of course, yeah, which I explain during other films and during our courses. It's not typical for an annular or a nuclear protrusion. It's not typical for a mixed protrusion. The fact that you have a partial articular pattern in combination with a painful arc is typical for an internal derangement. Well, could be annular, could be nuclear, could be mixed, yeah, but typical for an internal derangement which is small, easy, reducible. So, I hope that now some things became a little bit more clear. Yeah, okay. If you would like to have further inspiration, well, go to the Syriacs Academy page, and there you're going to find a lot of downloads on some blog articles, the downloads of the standardized assessment forms, a huge number of films to further inspire you. So, if you have any further questions, you know how to find me. Just send me an email and I'm going to be happy to help you. So, all the best and see you next time. Bye-bye.